Hey guys, Woodruff here. So we are in the home stretch. If you're in our adult med surg class, we are almost there. We're just finishing up with a load of crap. And when I say a load of crap, I'm talking about we're finishing up with GI and GU disorders. And so these lectures are just going to be over those disorders. I'm going to break them down by disease process to make them a little bit more manageable. And yeah, hopefully this is helpful to you. So we're going to start upper GI disorders by talking about nausea and vomiting. So this is a topic that most, compared to maybe other diseases and disorders that we've talked about, most people at some point in their life, if you are an adult, have had an experience with nausea, vomiting. If you haven't, then maybe you haven't lived enough. No, I'm just joking. But in reality, most people have had some sort of problem, whether it be an infection, pregnancy, what do you call it, surgeries, medications, things like that, that have maybe led you to having nausea and vomiting. So in my class, we kind of go and do a little bit, talk through some possibilities. But when we're looking at the top causes or the top reasons for nausea, vomiting, and there's a lot more than this, but I've underlined or marked some really big ones. Like I mentioned, pregnancy, it's one of the symptoms, especially early in pregnancy. There is an actual disorder related to it that I'm not going to try to pronounce because I'm not an OB nurse, and I try to only make a butt of myself like once or twice a day when I can help it, even though it tends to happen more than that. The hyperemesis, maybe no, I'm not gonna do it. I'm not gonna put myself in that position. But you guys know what I'm talking about. Hopefully, if you don't, you can Google. But yeah, so they can have the very severe vomiting, and also, most people that are pregnant at some point in their pregnancy have experienced some sort of nausea, aversions, things like that. Infection, so especially a GI infection, like most people have had a stomach bug at some point in their life where stuff is coming out both ends. It's always such good memories. And then also sometimes when you get like respiratory infections, you can end up swallowing some mucus and stuff like that, and it can make you nauseous. You can end up vomiting too. People with GI tract disorders, which we'll talk about later, are going to be more prone. This is one of the most common GI symptoms. So as you're doing assessments on a patient with a GI issue, this is a great symptom to ask about. Postoperatively, it's a result of the effects of anesthesia, can put you more at risk for being nauseous and or vomiting. And then if you remember, as we've, kind of gone through a lot of medications this semester, almost all of them like have some sort of GI effect, whether it's stuff upper or lower. But GI side effects are probably the most common side effects. And a lot of medications, especially on an empty stomach, can cause nausea. This is a great time to remember what those are too, to cumulatively remember, because HESI's coming up. Woohoo! So anyway, to kind of differentiate this, nausea itself, like if you had to define it, is it's a discomfort in the epigastric, which is the kind of where the stomach is into the esophagus. So like think of like your upper, the central part of your upper abdomen, and it usually comes with a feeling of the need to vomit. And then where vomiting is the actual ejection of contents. It's usually partially digested food and or gastric contents, gastric acid. Sometimes with nausea, vomiting, there's other symptoms that come with this. The patient may complain about a loss of appetite, fluid and acid loss, like dehydration, is something you would definitely want to look for, signs of dehydration. And then we're going to look for certain acid-base imbalances, which we're going to talk about soon. All right. So the priority assessments and expected findings we're going to see for this patient. When it comes to expected findings, like we said, we're going to expect to find discomfort in their epigastric area, and then also they may either complain of one of two things when it comes to vomiting. There's what's called regurgitation, and then there is projectile vomiting. So projectile vomiting is like in this picture of the oh my God, I was going to say The Exorcist. Yeah, The Exorcist. And for some reason I was doubting myself, but yeah, The Exorcist is that this is projectile vomiting is different in that it usually there's like no nausea beforehand, and it's forceful and fast. And so it kind of comes out of nowhere. Whereas regurgitation, you get that nausea and you feel stuff starting to come up, and it usually comes up slowly. And I don't mean like you're sitting there and it's just slowly edging up, but like think regurgitation like I know it's coming. Whereas projectile vomiting, it's like it comes from nowhere. And when I say it comes from nowhere, it's like there's no sign or warning that you're about to do it. For priority assessments, we want to assess the emesis or the vomit. With this, we want to measure it. That is, if it's present. Not every patient that has nausea vomits, but if they have emesis, we want to measure it to see how much, because that can give us a good idea. Like if I have a patient who's throwing up and then they vomit like a very minute amount, I'm not going to be as worried as if I have a patient, those like blue throw up bags. If they like fill up that bag, that's a liter of fluid and then a lot of acid and a lot of other things that they've lost, like electrolytes and things like that. So I'm going to be a lot more worried. So I want to know how much. So like when I call a doctor and say, hey, a patient vomited, even if I didn't measure it, like I couldn't get it in a bag because they vomited everywhere, I try to give them an an ish for like how much the patient vomited. So I'll be like, hey, they vomited about 250, stuff like that. We want to look at the color as well of the vomit. And, you know, we have to think about what we're expecting. And GI contents generally have colors of, I always think colors of fall. So they're usually like yellows, green, brown, bio-like colors are going to be what's most common. You might see some orange, so like colors of leaves and things like that. Usually the most common thing you're going to see is green or kind of like a brownish color. But you can have some other colors just depending on the contents. The things that are going to be more concerning are going to be if we start to notice that there is blood or signs of bleeding. If it's bright red, it's active bleeding. If it's coffee ground, which is kind of like, it looks literally like the bottom of if you've made coffee or if you've ever been abroad, like they literally give you just coffee grounds sometimes, like there's not really a lot of liquid and it'll get you hyped up. I'm not a caffeine drinker and I don't drink coffee, but when I was studying abroad, I remember just being like, holy crap, like it was something else. But yeah, so coffee grounds, it's like very black and kind of what do you call them? I'm trying to think of a way to say it without saying grinds. So yes, but it's just like a bunch of black particles, but definitely notice. So you're going to look for red or black colors are usually a bad sign. And you want to think about which of these is worse. Now, most people would say, ooh, the coffee grounds is worse, but I'll tell you this is that actually the bright red blood is worse. So if I have a patient who has bright red blood that they've thrown up, I'm going to be a lot more concerned because this is active bleeding. Like they are bleeding right now. There is something, they could have an arterial bleed. There is something that is bleeding from them at this moment. They have fresh blood. Whereas someone with coffee grounds, that could be something that has been regurgitated. It's been digested. It's digested blood. So it could be something that's older, but I'm not going to be as concerned because bright red is like now possible arterial, whereas coffee ground is more likely to have been previous bleeding. And it's not that it's not concerning, but I'm always going to worry about bright red first. And then we also want to see if there has an odor just to see if there's any sign of possible infection. And then, of course, assess their symptoms, the nausea and any other abdominal symptoms they might have, like pain, gas, bloating, that kind of stuff. So someone with nausea is better if their symptoms are improved, if they have no vomiting, of course, and no signs of a complication, where, of course, if those symptoms are getting worse or if they have a complication, then we're going to be concerned. And some of the major complications we worry about are going to be things like aspiration, because with aspiration, of course, you're regurgitating some of your GI contents, and those can accidentally slip into your airway. And your airway is supposed to be a sterile place, and your GI contents are very acidic, very harmful to the lungs, and then also could have food in it, which could attract bacteria and lead to pneumonia. Then also dysrhythmias we're concerned about because of the loss of electrolytes. So we need to keep a close eye on those, and maybe they could require things like, ECG monitoring, stuff like that. With the loss of fluid that comes with vomiting, they could be dehydrated. Or on the other hand, someone who's really nauseous is not going to be drinking fluid the way that they should. So we want to always consider that These patients are very high risk for dehydration. And then infection as well. Like they could get they could already have an infection, it could get worse and stuff like that too. But like I was talking about, like the aspiration pneumonia is probably one of the most common connected infections. And then we want to think about acid-base imbalance. So I know you loved acid-base imbalance back in respiratory. So let's get back and think about what acid-base imbalance this person would have. So it's not a respiratory problem. So it's not going to be a respiratory imbalance. It's a metabolic one. So it's either metabolic acidosis or alkalosis. And the way that I remember this is I remember metabolic alkalosis is like an alcoholic who drinks too much and then throws up. And so they're losing acid because they're throwing up their acid. So all they're left with is the alkalosis or the base. So that is, this patient's going to be most at risk for metabolic alkalosis, where when we talk about diarrhea, they're at risk for metabolic acidosis, because I always remember that the metabolic acidosis comes out your ass. So what medical treatments do we do for nausea and or vomiting? We want to find the cause, because at the end of the day, like we can treat the symptoms, but if there's something causing it, like if it's a medication, if it's a, what do you call it? If it's an infection, if it's something that's reversible, we want to get to the bottom of it. And so, like, for example, one of my students had a patient who was on iron, which, if you remember, iron is preferred to be taken on an empty stomach, but it can cause a lot of GI symptoms. This patient stopped taking her iron and came in with like a hemoglobin of 4 because of the side effects. So if we can get to the bottom of that and prevent that nausea, like not only are we helping her symptoms and improving her quality of life, but hopefully helping with her anemia as well. Also, we want to make sure that they're MPO most of the time till the nausea subsides. We do not want to be forcing any food in them. You know, sometimes it's hard because they're hungry and they really want to eat, but we try to wait for those symptoms to subside. We give them medications known as antiemetics. These are anti-nausea meds, which we'll talk about on the next slide. NG tubes. So we're going to talk about NG tubes a lot in this section. And what NG tubes can be used to feed people and to give them fluids and nutrition, like we talked about in the nutrition PowerPoint, but also it can be used for what's called decompression. What that means is that we put it in and it helps to suck out some of the extra air that happens. We swallow so much air. I saw something in the new textbook that said, like, oh, I don't remember, it was some very high statistic that talked about how much air we have in our bowels, and it was a ridiculous amount that I was like, I can't believe we have that much air in our bowels. But needless to say, what happens with this NG tube when it's inserted, it takes out that extra air, which can help to increase comfort and decrease bloating and decrease some of the symptoms and stuff like that that the person's feeling, and help to give them relief. But it also helps to, if there is like excess contents, because I didn't mention this, but some people have nausea and vomiting because they're over full, like they have too many residuals. Like, for example, if I have a patient who's receiving enteral feedings and they're getting too much, it's too much too fast, they can end up having those really high residuals, and eventually it's just kind of like the bladder. Like when the bladder gets too full, like eventually you're going to start leaking. It's the same if the stomach gets too full and it's not emptying quick enough and there's too many contents there, eventually it's going to just start backing up, and that's where you end up getting vomiting. So this is actually sometimes how we find out that someone's not tolerating their tube feeds, is that they'll end up vomiting. And then we're like, okay, maybe the rate's too high, maybe they need some motility drugs, that kind of stuff. But the NG tube also helps if there's too many contents, and provides relief, like I said, because it helps to decompress that stomach, and that's a lot of times what is causing a lot of the nausea-like symptoms. Causes the not nausea-like, but nausea symptoms, excuse me. There's also alternative nausea relief, like in this picture. When I was pregnant, I always had to carry around those alcohol swabs. And this was pre-COVID, so like I would sometimes have to sit there and smell one before I would go in certain rooms, because I would just feel very nauseous, or certain smells would really get to me. found it helped. But I've actually done that with some of these things too. So like, or I've had some people that get stuff like this and we literally rub it under their nose to help them like smell it in, and it helps to relieve their nausea. But sometimes if I have a patient who's getting acutely nauseous, I'll have them smell that alcohol swab. That helps too. We want to support good fluid balance because of the possibility of being dehydrated, either because they're not taking enough in or they're throwing up too much out. So we're going to, of course, encourage PO fluid if they can take it. But a lot of these patients end up requiring IV fluids. We want to monitor their intake and output closely. And watch for, changes. Because remember, when we get dehydrated, our kidneys get like, oh, no, how dare you? Like, very, you'll learn about this more in complex, but the kidneys are such a sensitive organ and they need lots and lots of flow. So the second that the flow is taken away, they get pretty temperamental. So we want to keep an eye on the fluid so that we can protect our kidneys, and they don't, because dehydration is probably one of the most common reasons people go into like an acute kidney issue. And then we also want to give electrolyte replacement. And it's not, I have glucose listed here, but also we want to think about our potassium, our magnesium, things like that. So watching those closely and replacing them as needed. My cat. So yes, here, let me get her out of the way. So yes, now she's probably gonna cry more, but this is the fun of working from home. Anyway, antiemetics are medications that are used to help with nausea and vomiting. And you're going to see these used for a lot of different conditions, and we can use them prophylactically before the problem happens or to treat the problem that's there. So, of course, these medications worked if there's less nausea or no vomiting. The three that you're going to see most commonly used, first one's called ondansetron. This is probably the one you're going to give most often in the hospital, also known as Zofran. It's very commonly used, minimal side effects, so it's pretty well tolerated. And they use this for a variety of patients, for everyday patients that are having nausea to cancer patients too. And some people this either tends to work for people or it doesn't, but it's definitely the first go-to, and it's the least invasive one we want to start with. There's also promethazine, Phenergan. This is one that is very popular among people because it's a lot stronger, and it also has a sedative effect. So, some patients will come in and they'll ask for things like morphine and Phenergan, or they'll, people that have issues with, we call it dependency and stuff on drugs can abuse this drug. And I'm not saying that everyone who asks for it is doing that, because a lot of people are like, hey, Zofran doesn't work for me, I need Phenergan. But it's just something to be aware of, that a lot of times patients want to go to this medication first, but we are supposed to try the least invasive first, which is ondansetron. Promethazine also has a lot of side effects. So it has the 3 Ds, the dry mouth, dizziness, and drowsiness. But it's also super dangerous to give via, via IV. Now, I'll tell you, the most of the time when I give this, it is IV, but it's meant to be diluted and given slow. And your previous textbook, your new textbook, I didn't see it anywhere in there. But I swear, I think it's probably maybe in your drug book or somewhere else that it talks about you're supposed to give in like the biggest IV that you have. And I want to say that you want to give it an IV that's closer to your body instead of farther away. But there's just a really high risk that if this goes outside of the tissue, outside of the IV into the tissue, that there's a high chance of you having necrotic tissue and losing a limb. So you want to be super careful when you are using this. The preferred route is, of course, oral or rectal. They have IM as well, but and I think your previous textbook used to say like, hey, the preferred route is IM. But this for Phenergan, it just depends on what the doctor orders, but just caution with IV use, and then make sure that you're giving it correctly. And then, like I mentioned before, using the least invasive first. Last but not least is what's called metoclopramide, also known as Reglan. And we talk about this for a variety of things. We can use, I talked about it a little bit when we talked about gastric motility with enteral feeding. And what we want to remember is for what do you call it, medications that like this is that they're specifically helpful for patients that maybe have that overfull stomach that we're trying to help to get things moving. So like metoclopramide, you can think the M is going to be for motility, and so it's going to help to like the sphincter that's in the second part of your stomach that helps to empty into the intestines or the duodenum. This is going to help to have that empty more regularly so that you're not getting so full. So this is great for patients that have too much in their stomach, helps to get things moving. We do sometimes use it for nausea in general if other things don't work, but there is concerns for dysrhythmias, involuntary muscle movements, also known as tardive dyskinesia. So it has to be used cautiously. It's associated with, and I talked about this a little bit when I talk about cardiac stuff. I always get so happy saying cardiac again, but so many months till cardiac comes back in my life. So sad. Anyway, actually, the next slide is kind of cardiac too, so get ready. But needless to say, one thing to know about Reglan is that it can also, with the dysrhythmias, it's considered to be a drug that can prolong your QT interval. I know that's a fancy thing to say, but what I'm saying by that is that it's a medication that can have an effect on how long it takes for pretty much the time between each heartbeat. It prolongs that, and it's not that it slows the heart rate or anything like that, it just prolongs some time. And if you're taking this with other meds that do that, you can end up having a longer resting period of your heart, which sounds like a good thing, like, oh yeah, great, more filling time. But here's the thing, the longer you're in that resting period, the more likely you are that your heart's going to get impatient and it's going to do another beat. And remember, during that rest time or that T wave, we really want to be resting. We do not want to be having any extra beats. So if you remember my toilet analogy, it can lead to like abnormal. It's kind of like, imagine if you flushed your toilet, it's refilling, and then you got impatient because you added a little extra toilet paper at the end and you're trying to flush again. And it kind of flushes, but it's making like weird gurgly sounds and you maybe broke the toilet. That's the same thing that can happen with a prolonged QT interval. It's like when you're trying to flush again, but your heart's not ready, it hasn't filled, and it's not ready for that next beat. So this is the same thing, how it leads to dysrhythmias like VTAC and stuff like that. So just know that in case if you're a cardiac god or goddess, and hopefully that helped you. If you hate cardiac, I'm sorry, you're missing out. Anyway, let's do a practice problem. And you know me, I always like to bring back the EKGs. All right, so which of the following rhythms would be a sign of a common complication of nausea and vomiting? Let's dig in. So this first one, we have let's count, let's do our systematic method. Let's see, let's do count the rate. 1, 2, 3, 4, 5, 6. It's got a rate of 60 because I have 6 QRSs and I times by 10. It is not regular. It has different space in between each beat. I don't see regular P waves. I see a bunch of fibrillatory waves. I see a skinny QRS. So I have a top of the heart problem. So if I have a regularly irregular rhythm, no P waves, top of the heart problem, this must be AFib. So let's identify the rhythms first, and then we'll figure out which ones we'll answer. So let's do this one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So 14 times 10 is 140. So I've got a rate of 140. It is regular. I have a P wave, a QRS, and a T wave. So everything is normal. Skinny QRS, everything looks normal except it's a little fast. So if everything is normal but it's a little fast, I have sinus tachycardia. It's this one. Excuse me. What was it? Don't mind me dying. 1, 2, 3, 4. I know you're wondering, why didn't I count these? These aren't real beats. So I've got a rate of 40. With the beats that are back to back, it is regular. There's a P wave, a QRS, and a T wave. So it's slow because what do you call it, of these extra beats, but it's like a sinus bradycardia. And then what are these things? Do you remember? PVCs, baby. You know you love it. So what do you call it? This is a sinus bradycardia with PVCs. And if you're getting fancy, you would say sinus bradycardia with multifocal PVCs. Now let's look at this last one. 1, 2, 3, 4, 5 times 10 is 50. So this is 50. It's regular. There's a P wave, QRS, and a T wave for each beat. The QRS is skinny. And yeah, so everything is regular except it's a little slow. So this one is going to be sinus bradycardia. And so we have AFib, sinus tach, sinus brady with PVCs. And probably this strip, I think all these got cut off. So don't worry, don't get too caught up on the sinus brady. It's just think of the PVCs. And then we have sinus bradycardia. And so which of these are a common complication of nausea and vomiting? So we want to go back and think. So like complications were things like aspiration, infection, fluid and electrolyte imbalances. So really what I'm testing with your knowledge here is what does it look like on your EKG when you have those problems? Are there any changes? So one thing I need to remember is that when a patient is dehydrated, what happens? They have less fluid. So what does the heart do to compensate? What do you think? I think it increases. So down here with the sinus tachycardia, this would be a sign of a complication of, what do you call it? The nausea vomiting, because it could be a sign they're dehydrated. Also, if you want to get super fancy, if they had an infection and had a fever, they also could be sinus tachycardia. All right, so that's one. The other thing to consider is that they can have electrolyte imbalances. So which of these would be indicative of electrolyte imbalances? I know some of y'all are probably thinking AFib, but most of the time that's like respiratory issues, and it's more related to an irritable heart versus the nausea vomiting. It's possible. I wouldn't say it's common. So which then I'm kind of down to these two. Sinus bradycardia, I don't think there's anything about nausea vomiting that would cause your heart to slow down, and there's no meds you would take that would slow down your heart. So I think the only other one that might be possible is these PVCs, because if you remember, one of the most common reasons you get PVCs is because electrolyte imbalances. So the two that are most commonly related here to nausea and vomiting complications are going to be the sinus tachycardia and this sinus brady or normal sinus, whatever, with PVCs. All right, so what's my role to help prevent complications? Again, we're worried about dehydration, infection, and I guess the other reason we're worried about infection is we're not getting nutrition, so we can't heal the same way. I'm worried about aspiration and dysrhythmia. Dysrhythmias. Anyway, so anytime you hear about electrolyte imbalances or fluid imbalances, you really want to think heart and kidney problems and dysrhythmias. We also want to be concerned about hypoglycemia, because if patients aren't eating, like I said, it's glucose they'll be needing because they're not getting in the sugar stores that they need in order to support their body. So what we can do is we can watch those electrolytes closely. Like I talked about ECG monitoring, kind of keeping close, watching for rhythm changes and for any other changes their day to day. Then we also want to make sure to protect their airway by keeping their head of bed at 30 degrees. We also like to put them, like if they're vomiting, especially if they're not as awake, I like to put them in a side lying recovery position. And it allows, because if I'm laying on my back and I throw up, all it has to go is back inside myself. But if I'm turned to the side, it can help it to go out instead of back in. And then, of course, I need to monitor for hydration. And I always ask students, like, what's the best way to monitor for hydration? And when you think about this, when you think about hydration, what you want to think about is your kidneys. Most people would say like skin turgor or mucous membranes. And skin turgor, honestly, that's like a very late sign. Mucous membranes, okay, they can get dry. But the best thing that you can really do is see how their kidneys are doing, because the kidneys are so flow sensitive. If I'm getting less flow, you are going to see a big difference in my kidneys, my urine output. So urine output is probably one of the best ways to tell about hydration. Also, blood pressure can be a more sensitive indicator. So what should someone who is having nausea vomiting be eating? So they call it sometimes the brat diet. What is it? Bananas, rice, applesauce, and toast. And I think that's the brat diet, but if I'm saying it wrong, you can forgive me because I'm not perfect. So with nausea and vomiting, we want to eat foods that are high in carbs and low in fat, because the fat can be irritating. We want very bland foods like baked potatoes, rice, and cereal. We can drink water, carbonated beverages at room temperatures. We don't want it too hot or too cold because it can be very irritating to the stomach. We want to stay away from things that are spicy, fatty, and acidic. Anything with strong odor could be very irritating. And then always listen to what your patient is telling you is going to feel better, because everyone's a little different. For me, like no matter what, if I'm sick at my stomach, I want Canada Dry. Like when I'm sick in general, it's just a thing how I grew up. I remember just sitting at home and watching Price is Right, drinking Canada Dry and eating ramen, and it always made me feel better. And so now it's kind of like my magic fix when I'm not feeling well in general. And now it makes me really want to go get some Canada Dry and ramen. Just as an electrolyte review, for those that may need a little bit of a refresher, your potassium and magnesium levels are here. This is a great thing to have on your note card. You're definitely going to want to know these electrolytes. You always need to think about kidney function, like I talked about. So 0.6 to 1.2-ish is it's different for men and women, but this is a good number to go by. And then definitely, like I said, you want to keep them on a cardiac monitor, because a lot of these patients are going to be super at risk for those cardiovascular complications. So big picture, nausea, vomiting, keep them hydrated. What do you call it? The best that you can, oral or IV fluids as tolerated. Watch for electrolyte and other fluid imbalances, prevent aspiration. One other thing that I didn't bring up in the PowerPoint that I probably need to add is oral care. Oral care is probably one of the nicest things you can do for a patient that has nausea and vomiting, and that includes for like other GI disorders. Like sometimes there's nothing we can really do to make a person with nausea, vomiting feel better. Like we're giving them meds and it's taken a while to work, but if we can keep their mouth clean and it also helps to prevent more of that like distaste from having vomited. So keep up with their oral care, and be keeping a close eye on their comfort when it comes to their mouth as a whole. So give them opportunities to brush their teeth, or at least to use swabs to clean out their mouth, because it can definitely make a big difference. But yeah, that's the big picture. Find the cause, treat the symptoms, and prevent the complications. See you for the next one.